Hello, good afternoon, and welcome to the latest in this series of NR Times Roundtable discussions. And today we're going to focus on the critical subject of surviving brain injury, and even more specifically, how we rebuild lives and families from those that are surviving with brain injury. Well, we've got an absolutely fabulous group of panellists with us today who are ready to share their knowledge and their experience and their views. And I'd like to ask each of the panellists just to introduce themselves, say a few words about who they are, a little bit about their organisation, and of course their areas of specific interest. And then we'll push into the more general discussion. So if I could start with Jenny and Kirsty from QEF.
Hi there, good morning. My name is Jenny de Canha. I'm the Head of Clinical Services here at the QEF Care and Rehab Centre in Leatherhead. We are a 48-bedded inpatient rehab unit, and we see predominantly clients with neurological injuries, and many of those obviously are ABI. And with me today I have Kirsty. She'll introduce herself now.
Hello, good morning everybody. My name is Kirsty Catling and I'm a clinical lead speech and language therapist for QEF. My clinical interests include student education, professional development, and also acquired communication disorders after brain injury, so cognitive communication disorder and aphasia. Very pleased to be here supporting QEF. We have a great sort of culture of MDT working, so it's great to be here. Thanks for having us.
Great, thanks Jenny, thanks Kirsty. Gayathri.
Hi, I'm Gayathri Burrah. I'm a consultant psychiatrist working in St. Andrew's Hospital. So I'm the consultant overseeing Elgar ward, which is a 12-bedded acquired brain injury unit for female patients. It's the only female ward, and it's part of a bigger pathway of nearly 70 beds, ABI beds. I'm basically an older adult psychiatrist by background, but for the last 5 years, I've been working in neuropsychiatry and developed quite an interest in managing people with ABI.
Great, thanks Gayathri. Mira.
Hi, my name is Mira Akar. I'm the lead speech and language therapist here at the Bridge Care Centre, Elysium Healthcare. We are a 40-bedded complex neuro-rehabilitation setting. So we work a lot with brain injury, spinal cord injury. We've got a full MDT here. And my main areas of interest and expertise is working in dysphagia, AAC, communication, cognitive communication, aphasia, and so on. And thank you very much for having us here.
No, great to have you as a panelist, Mira. Thank you.
Thank you.
Jenny, can I ask you to introduce yourself, please?
Yeah, hello, and nice to meet you all. I think there's a few familiar faces that I met here before. I'm from Think Therapy First, and we're an occupational therapy company. So we work primarily, exclusively really in the community, in people's own homes, after serious and catastrophic injuries. And I would say about 60% of our workload is brain injuries, usually after an accident or an incident. So yeah, thanks for having me.
Thanks, Penny. And Jane, last but not least.
Hello, I'm Jen Mellows. I'm Clinical Operations Lead at Hobbs Rehab, and I am also a speech therapist. This is like the biggest professional group of speech therapists I've been with for a long time, which is just lovely. So for those who don't know, Hobbs Rehabilitation are an inpatient, outpatient community provider of specialist neuro rehab, and we provide MDT inputs, so physio, occupational therapy, speech therapy, neuropsychology, rehab assistance, with a focus on intensive rehab packages and neurotechnology and developments in neurotechnology. So we have a really broad ranging client base, but quite a large ABI client base in inpatient and outpatient and communities settings as well.
Thanks, Jane, and thanks again to all of our panellists for being with us today. I'd like to go round the table, starting again with Jenny and Kirsty, and ask each of our panellists what they think the critical factors are in surviving brain injury well and in rebuilding lives and families successfully. If I could start off, Jenny and Kirsty.
Yeah, I mean, it's a big question, and I think there's many challenges that clients of ABI are facing right now. And I think probably in terms of the critical factors, the funding that's there really supports in those early stages post head injury, where impairments and challenges are much more pronounced. And I think in those initial 6 months, the funding is there to resource and manage that. But I think it's the time that happens beyond the 6-month phase is becoming a real challenge, and clients are discharged home with many hidden disabilities that are really making their ability to function and have quality life really challenging and really difficult. And I think the resource and service for those types of clients, once they do go through that acute phase, is becoming more and more challenging. It's almost like in those early days, they get that full MDT approach, and then come 6 months home, and you're really going silo and on your own. And then that's when a lot of other of the hidden disabilities that we speak about start to surface. And living life long term with a brain injury is really challenging, and it can have an impact on many other roles and aspects of one's life. And I think for me, that's one of the areas that we really want to focus on, because we are predominantly an inpatient rehab unit, but we do also offer outpatients and want to reach into the community. And so for us, it's really thinking about how we can serve our clients in the community to help them manage those challenges. I'll hand over to Kirsty as well, because she might want to add to that.
Yeah, I think that I completely agree with Jenny's point there about a lot of the funding focusing on those initial 6 months and sort of getting people home, but it's actually what happens after that, because living with ABI, it's a lifelong condition. There's lifelong ramifications, and I think it's around supporting relationships in the community, supporting meaningful activities in the community, rebuilding your sense of self, rebuilding your sense of identity. Maintaining successful relationships, because I think that's the research tells us that a lot of relationships sadly break down after acquired brain injury, and that has huge ramifications for people's mental health. It is really complex, and I think that focus on what happens in the community is really needed. Oh, we can't hear you, Alistair. Sorry, I don't know if that's just us. Our audio's gone down.
No, it was me. Just checking that you were paying attention, Kirsty. I was actually just about to say, and there's a danger in that, as I've just demonstrated. When we're not speaking, can people mute themselves? There's just a little bit of background noise. Apart from me, because if I do it, I'm going to keep forgetting. Gayathri, can I come to you next, please, with the same question about what you think the critical factors are?
I'm basically going to echo what Jenny and Kirsty said about we do in the hospitals. It's an MDT approach. We throw everything at the patient to get them better, and we send them off into the community with almost absolutely nothing and expect them to carry on with life as normal, now with the added burden of an ABI. And you're failing right at the start. And I think that that is a huge part of recovery, having those appropriate services in the community. Even when we are identifying these appropriate services, there's often a gap between, the move from hospital to community. And it's, patients often relapse before these services kick in and start providing, the aftercare that's needed. I think the second critical factor, and there isn't a lot that you can do about it, is when we see patients successfully managing in the community, it is often when they have that social structure in place, when they have family and friends to support them. But family and friends also need the backdrop of these services. So when you have both of them working together, that's when we can see patients succeeding, despite all the physical and mental health challenges that they have. So I think it's these, for me, these two are the important sort of factors.
That's really helpful, Gayathri. Thank you. Mira?
Yeah, I will follow up on Jenny, Kirsty, and Gayathri's comments there. Knowing that we receive our patient from an acute centre or from a hospital or so, we do struggle sometimes to support them, especially on the emotional, psychological level. We're not just talking about the patient, we're talking about the family members as well, because both are grieving the life they used to have, and just getting used to a new life, new abilities, new person. And it's basically finding where we would signpost them and where we could just signpost them to where they could get this support and this help so they can progress further with their therapy. Again, we are an MDT here, but you need this emotional and psychological support to tackle a bit like the denial, the acceptance of the pathology, of the new life and the new abilities to progress further with the therapy.
Thanks, Mira. Thoughts, Penny?
There's three critical things for me. The first one is probably most obvious. It's diagnosis, and it's probably where I think a lot of us feel that the resources aren't quite as bad generally, but still people do get missed, especially those more hidden brain injuries. We see people with a lot of catastrophic, quite global injuries, and it's only once we're doing the rehabilitation we start picking up on there likely being a brain injury and having to try and get them back in. And they're not really triggering getting back in to get diagnostics, which can be a problem in the first place. But the more we work with someone, we work very intensively on functional rehab programs, we're seeing it, their families will be seeing it, we're noticing the difference. So I think there's something for diagnosis primarily. And then echoing what everyone else has said, that access to rehabilitation, and rehabilitation that is both physical, cognitive, and has a great MDT. And you're going to move within that rehabilitation from specialist centres if you're lucky enough to have access to that. But some people might hit generalist. And so there's a need there for my third one, which is education. And that's education for the client, education for their families, and education for professionals that don't specialise in brain injury. And then even wider than that, education for the general public, because to reintegrate people back into the communities, as we've all said, that's most successfully done when there is a community, when their roles and their life, they've got meaning and purpose in their lives, and that usually involves getting people back into work. But it's hard to maintain a job and relationships and family structure and even a home when you've got a brain injury, particularly with some of those more invisible symptoms that persist throughout someone's lives. So the people that do well have access to all of that, from the diagnosis right through to the rehab, right through to the education, and that happening with the wider community and having good networks.
That's a great summary, Penny. Thank you. Jen, anything that you'd like to add to that?
I mean, obviously, I want to echo what everybody else has said, because we're all talking on the same themes. There's a lack of access, there's a lack of funding which enables that access. But I want to pick up on, even when people do have access to rehab, and I'm not necessarily talking about those of us on this panel who are fortunate to work in some incredibly high quality rehab centres, but when people do have access to rehab, it's often not ambitious enough. So people are focusing, certainly in the very acute stages, on getting well enough to go home and accepting the limitations of their brain injury, possibly too early, and making compensations too early to enable a discharge home, rather than thinking about what is the best type of rehab to put in to facilitate a lifelong change for this person. So for me, it comes down to viewing brain injury as a lifelong condition, not just treating it in its sections, which I think is something that happens across the board. So we quite often find that people will come out to us having been told they're going to be wheelchair users for the rest of their lives. We're thinking, okay, well, maybe we can change this. Maybe we can do something about this. Similarly, with communication, with interpersonal relationship building, with returning to work, these are people who are going to be living with brain injury for their whole lives, and we need to be ambitious for the quality of their brain injured life from the get-go. And for me, that includes funding for people to be able to re-access rehab. Because even when we can get rehab funded, and we're very fortunate that we managed to get fantastic packages funded at all of our centres for people, getting them to be able to remain in the system and come back into the system for the rest of their lives it's very, very difficult to achieve. And I think if we can crack that, no small task, then we might stand a chance of supporting people for the whole of their lives rather than their kind of rehab phase, which seems to be considered as something that stops after a finite period of time.
Yeah, thanks, Jen. I'm sure we'll come back to that question of, having hope and ambition and, a clear pathway, not just for individuals, but for their families and those people involved with them as well. Jenny's just joined us from Cleveland Clinic. Jenny, can I ask you to...
Oh, sorry, I'm late.
That's fine. We'll just grab the opportunity to let you introduce yourself and say a few words about the Cleveland Clinic and the work that you do. And then we've just went around the table and also asked people for their thoughts on what the critical factors are in surviving brain injury and the impact it has on, lives and families. Could you maybe pick that up, and then we'll get back to the more general discussion?
Yeah, sure. So very briefly, I'm Jenny. I'm the lead physio for our rehab unit here at Cleveland Clinic. On the 29th of March, we will have been open for 2 years, so we're a relatively new facility, but we're a multidisciplinary service, a private hospital. We've got physio, OT, neuropsych, speech and language, healthcare assistants, and a fully integrated rehab unit. And one of the positives is that we're within an acute hospital, so we have a lot of access to consultants and getting medical opinions quite as integrated into a patient's rehab journey. And I'm sure it's not news to anyone. I think some of the keys for surviving or managing or succeeding after brain injury is peer support, as well as that professional education and all of the things that we as therapists provide. I think there's a lot to be said for having access to others who've been through that, and also for patients' families to have access to that, because I think we vary in how successful we are at integrating families. I think sometimes we use them as our resources initially, but potentially towards the end of someone's rehab journey, we could improve on integrating them into managing their needs towards discharge.
Thanks, Jenny. That's great. Rather than go around the table again, I'm just going to, ask a couple of questions as prompts really for the discussion, and I hope some of our panelists will volunteer thoughts. We will talk about barriers, but I'd like to start off by talking about where the opportunities lie to continue improving the way in which people can survive brain injuries. So would any of our panelists like to sort of volunteer their thoughts on where the big opportunities lie to see further improvements or to accelerate improvements that will tackle some of the critical factors or improve some of the critical factors that we've mentioned in that first question?
I think maybe from our side of it, certainly we've touched on it a little bit already, but it is about the links and the networks. So for us, it's trying to find out and establish what resources are out there. We are a charity, and we do support clients that are from the NHS. We support private clients, case managed clients. They can come through, say, the ICB funding from various different geographical locations. And actually for me, it's really important that we can try to understand all of the different services and resources that are out there and what their specialism and niche is, so that we can signpost appropriately. We've all spoken about families and peer support. for us, we've also really recognised the challenges here at QEF, and we've talked about it quite a lot in terms of when they do leave this intensive, busy, dynamic environment where there's lots of people around, how can we support that onward transition home, which is so huge and can be really scary and almost heighten some of the other challenges that maybe are less heightened in the earlier days, challenging behaviours, things like that. So we have now developed a link and a partnership with Headway and the Stroke Association, and they are now coming into our service on a regular basis to see clients and families so that they can have that initial contact and face-to-face connect before they go home. And that's to try to ensure that there is some form of transition home with that familiar face, and that people don't feel completely alone, because whilst we are delivering therapies here on an MDT perspective, the Stroke Association Headway offers something very different, and they can also help to signpost in terms of peer support groups, create just different opportunities at the client for the client once they go home, so they don't feel alone, and they also support the families in that too. So I think for us, that's something that we want to continue developing and continue working on to see how else we can signpost and join up care so that clients don't feel so isolated once they leave our inpatient setting.
Can I? Is it right?
Yeah.
Sorry. I'll let the chair decide.
When you go, Jen, and then Penny can come in after you.
I was just going to chime in with what Jenny had said about the networks. And for us, that's been a huge change in the last couple of years, is our ability to work with our NHS partners. And since the supposed join up of the NHS and social care arms, I think there is an opportunity for slightly more creative service planning for adults living with acquired brain injury. And our sense is that the NHS are slowly coming round to that way of thinking, whereas before it felt very much like, actually, I don't know who to speak to, there's nowhere I can get in, this service deals with this and this service deals with that. They are starting to think cross pathway, they're starting to think longer term. We're starting to be able to get a little bit of more seamless transition of care for our NHS patients. But the problem is that so frequently it's reliant on individual networks. And typically the therapists, because we all know each other, the therapists or the staff who are working on the ground to know somebody who works in this environment or know somebody who works in that team, to have a personal connection with a commissioner or the manager of Headway or whatever it is. And without those personal links, the system breaks down. So there's definitely an opportunity for joining up at a system level rather than relying on those individual links. And my sense is that certainly with some of the NHS organisations we're working with, they are starting to open their eyes to those possibilities and be less frightened of these networks that are out there that actually have the potential to serve these patients across the whole pathway. So I've got my hopeful hat on at the moment and thinking that things might change.
That's really positive, Jen. I was going to ask about whether or not public and private sector provision was meshing. It sounds as though it's in the process of doing so.
It's small steps, but it certainly feels like it's changing, which can only be a good thing for patients.
Yeah, absolutely. Penny, you were going to come in.
Yeah, I think for me, the single biggest opportunity that will probably have the biggest impact on improving things is technology. And some of that ties into what's just been mentioned, because I think you can use technology to educate. I mean, social media now is such a accessible platform, and there's so much that can be done on training everyone. I call it training, but just educating people on brain injury and creating networks and links for that peer support mentioned. But also I think technology's got a big part to play in pathways and networks and mapping and directories. That at the moment, what you guys were talking about, it's so, and we have this, we're a national company and we build the MDT locally around the client with a merging of private and sometimes charities and other sectors and NHS and social care, we never detach from that, because once we're no longer involved, that network hopefully is built and will continue supporting that person for the rest of their lives. We're quite aware that we're in and we're out, but I think that the ability to integrate and do all of these things that we're talking about can come from technology in a much more seamless way. And in that as well, the other opportunity that might bring is some outcome measures and evidence base, because it's so disjointed, and I'm sure we're all collecting stuff and in our own little pockets we know what works, but hearing you all, it's the same stuff working for you guys, for the client, that's working for us. So I think there's opportunity in tech as well to bring that together.
Presumably, Penny, technology could play a big role in some of the issues that Jenny from QEF talked about, making sure that people had access to the right services at the right time, because using technology, you'll be able to see exactly what is available, and there won't be a postcode lottery, one would hope.
Exactly. I mean, the Child Brain Injury Trust have launched their directory. I don't know how many of you are on it or use it, but we certainly do. But at the moment, it's still building. But that in itself, it means you can find, we have to get very creative finding local resources to meet people's needs. We use local occupational therapists, which means we've got that knowledge of the service, the NHS, social care, we've got specialists in those areas. We're very lucky, but you're right. At the moment, it's based on that person. In the future, technology can be the one bringing that all together. Yeah, absolutely.
Any other thoughts on opportunities? Gayathri?
I basically use every platform that's sort of available to sort of improve our knowledge and skills of neuropsychiatry. I also do a lot of teaching and training for medical students, and these are future doctors. We also have nursing students, physician associate students. So we use this as an opportunity to improve knowledge and awareness of neuropsychiatric problems, and I think this is an important part. When you have students coming through an organization, and whether you're private or NHS, there's always that opportunity, and I think that is key for me. The other things are the ones that have already been mentioned. So the local links with Headway. So we've got a nice sort of link with our local Headway, but where there is an opportunity, we also try and integrate our patients into the services that are already available. So, whether it's local charities, for mental health disorders. So if it's possible, we do try and get our patients to join the mainstream services. And that helps to raise awareness about ABI as well. I think that's all I have to say for now.
Great, thanks, Gayathri. I suppose, having talked about opportunities, we should also recognise that there might be some barriers to progress as well. Would anybody like to pick up on that theme, where there are barriers that can be removed and allow more progress more quickly? Gayathri?
So I think the key thing, so when I'm looking at someone moving on from our service, so I think the key thing is name tags. So, the fact that you're looking after a patient with an ABI, and you may be discharging them to a place where there are no ABI services available. And it's the reluctance for the services that are existing to take on the patient and offer them the appropriate sort of aftercare. So even when when our team is ready and willing to educate and train and sort of support these services, there's quite a lot of hindrance and a lot of, this is not our field, we don't want to look after them, and it becomes quite difficult. And that for me is the biggest sort of hurdle. Because you've done the necessary sort of assessments. There's baseline sort of assessments available in all aspects of the patient's care. You've got them on appropriate treatment. You know what is needed in the future, and you've sort of put safety nets in place. And the biggest hurdle is, how do you move them on when the existing services are reluctant to take them on?
Thanks, Gayathri. Kirsty, did you want to come in there?
Yes, I was just saying, your question was about barriers currently, wasn't it? So I think for us, one of the biggest barriers is we've talked about this already, but is the lack of sort of community services. So it's the issues in the NHS at the moment for us that are really problematic, I think. There are huge recruitment, retention, high vacancy rates in the NHS. So services are really struggling. Our local services, wait for physio can be 6 months, wait for speech and language therapy up to 2 years, in the community. So I think that is a huge barrier. And I also think that, that feeds into, and also, trying to find a psychologist, a neuropsychologist in the community is virtually impossible. So that's a real barrier, and lack of support for families. So after brain injury, you often see a great deal of stress being placed on the, partner or other family member, particularly if they've got young families, then they're then having to have this sort of large financial burden. And then, that can lead to, them having some mental health problems. And, access to mental health services in the NHS for those people is really struggling. So I think that's a fundamental barrier, really, is the struggle that NHS services are facing.
And the other thing, just to feed on to what Kirsty's saying, is I think that when they do come to us for inpatient rehab, as we've touched on already, they get an intensity, across the spectrum of the different disciplines. But what I would really like to see evolve and move forward is that it is lifelong care, and that there's an opportunity for them to come back to us for reassessment and review. And if it is for a very focused type of therapy, that then we can look at how we can develop and support that, because things change. Everyone's life changes as it moves forward. It was just experience, let alone with a brain injury on top of that. And we all know that the challenges will go with that. And so for the client who comes here with their families and loved ones, they may not actually be ready and even wanting and consenting and open to dealing with having counselling or dealing with the educational side of living, with head injury and what that looks like, because possibly at that point in time when they come to us, the focuses are very much regarding a physical aspect of their recovery, or, something that is deemed to be more important at that time. And it's only once that they leave that this then evolves and the catastrophic sort of reality sets in when they get home. Well, actually, my wife or my husband can't go back to work, or they can't look after 3 children and do every school drop off and run into town and get the shopping. And, so it's the complexities of life. And, when they're here in this bubble of inpatients, they go. And so for me, it's that access for it to come back to us for a full, thorough MDT review with the consultant on board to really understand and identify what the key challenges are and the blockers to living the meaningful life, and then being able to support them with a bespoke rehab package with the staff that have the skill set to do that, to then allow those meaningful changes and outcomes. And for me, I'm really passionate about that, and we're really trying to look at that as a service.
Can I just look up on that as well? So I know that we're talking about lifelong treatment and lifelong care, but for us, one of the barriers has been, again, coming back to that ambition of rehab. And because of the limitations that are placed on funding of statutory services, not being able to get people into the services and into the systems that do exist, because we're all out here, we're all doing it, to enable them to make those meaningful changes earlier on. And it used to be very much that, reducing carer burden is a social services cost and acute health wouldn't fund it. So getting functional rehab early enough on in the pathway to be able to make a real meaningful difference, to actually affect change that enables somebody to then live a fulfilling life with brain injury, used to be nigh on impossible to fund. we had a fantastic case study of a patient that we managed to get funded by the NHS for an intensive rehab block, and she had school-aged children, and her husband was going to have to give up work to care for her and her children. I don't know how we did it, we managed to convince the NHS to fund her a sort of 6-month block of rehab that followed her intensive inpatients, following her out into the community with a transitional living package and then some outpatients. And she went home with very, very minimal care needs. Her husband was then able to return to work. She had speech and language therapy and neuropsychology as part of her rehab, which enabled her to work on communicating with her teenage children so that she could not only manage their day-to-day life and all the school stuff that comes with you, but actually talk to her teenagers. This is a lady who had quite significant aphasia. Without that input at that really early stage in her rehab journey, she'd have gone home with a 4 times a day double-handed care package. Her husband would have had to give up work. She would have really struggled to be a mum of 2 teenagers, and who knows what their lives would then have ended up at. So it's really frustrating that for some people those opportunities exist. So she did incredibly well, but it's not the case for everybody, and you have to fight every step of the way to make those things happen. But it just shows you that there are opportunities within those barriers. If we can just get those kind of stories out there and let people know what's possible, maybe we can start breaking them down.
Thanks, Jen. Mira, I think you wanted to come in.
Yes, Alistair, thank you. So a bit echoing what the panelists were saying, but also adding up, yes, we do try to signpost people, and we try, like, we link in with Day One Trauma, let's say, and so we try to sign people to go where they can get some help. But then again, we struggle because we are talking about traumatic brain injury. When it comes to the support with mental health, there's a lot of overlapping, and sometimes some of the referrals, well, we try and get them through, but some of the referrals just bounce back. Just because they have traumatic brain injury, that doesn't mean they cannot have also mental health that it needs. So this is a massive barrier that I think our patients and our residents, like any other, suffer from, is getting through mental health support while they also have a traumatic brain injury as well. One of the other things that I'd like to highlight is the funding again. So even if they get discharged back home, getting back to be reassessed again, because they could have improved, they could have lost some of the abilities, because again, we're not having the same intensity of therapy. So how do we get these patients to get reassessed throughout the period that they were discharged home? And again, it comes back to funding, and so just to review changes, review needs, and support these family and patients.
Right, thanks, Mira. Penny?
Yeah, I think just hearing everyone and just the way I suppose my brain works, resources is the fundamental issue, and how they're allocated. But I think if you go even a step above that, it's the current system setup. It's the fact that health and social care are not joined up as much as they say they are. They're different pots of money, and no matter how integrated they try to make them, at the moment under the current system, health is separate to social care, which is also separate to the Department of Work and Pensions, and that fundamentally is the problem. Because until, one of the benefits we have is if there's an insurer on board and they're funding, well, they care about the health, the social care, and the Department of Work and Pensions staff, not those departments individually. But the claim, if the person gets their life back, care costs are less, the ongoing impact to the wider community is left, they get back to work. And so at the moment, one of the things, I think we talked about opportunities earlier, some of the opportunities we have with that private kind of funding when people have got a claim going is that it's under one umbrella of funding. You haven't got these different pots and that's the other issue, is that people don't understand this system in the NHS, and these systems in not just the NHS, actually, it's the whole system across it. But also the public doesn't understand how that's separated or have any sight or concept of the cost of rehabilitation and care ongoing. And so the one thing we do find, it's another barrier for us, I don't know if you guys find it, is when someone then has their settlement, they take their money and they go and spend it on something other than rehab and expect the NHS to pick it up. And we're at the moment following up on people that have done that, and we follow up anywhere a couple of years after people have ended therapy with us, and we are finding those people are in, their relationships have broken down entirely. They didn't keep their job. They did when they left, but they haven't kept it up, and they didn't do their rehab, even though they got a big pot of money for it. And some of them have even cancelled care packages, and that's what's led to relationships breaking down and families not being able to deal with it. And some that we're struggling to follow up may well be in prison because that aftercare and that thing are all across it. So when we talk about barriers, it's the whole setup. We talk about resources, but it's actually a symptom of a bigger problem.
That's helpful, Jenny. So, resources, funds, money need to follow need, not the other way around. Jenny, did you want to come in there? Jenny from Cleveland.
Yeah, I was just going to say, obviously, we're in a slightly different position. There are still funding constraints, but we're very privileged that most of the patients that are attending our facility have separate sources of funding, be it private insurance or personal. And it can still be a barrier to their ongoing recovery. I think people's understanding of how things are going to be very expensive in the future. It's not just a short period of rehab that's going to fix all of their problems. I think the other barrier, though, can be our expectations and how potentially we restrain people from how much opportunity we give them and what we think that their outcomes can be. And understand that the NHS, again, is trying to get that primary function to get people discharged. And we, again, have an opportunity to try and be a bit more personalised. But I do think as a whole, we limit our expectations of what people with brain injury can achieve. Thanks,
Jenny. I think we've touched on the subject of education and awareness through quite a few of the comments. Would anybody like to sort of volunteer any thoughts on how critical that is? Because it seems to me that there is a general lack of awareness when it comes to understanding quite how complex and demanding and long-term care plans need to be for individuals. And of course, their families and dependents and those people that are close to them.
I mean, yes, I think everything, we're all on the same page with lots of things I've mentioned, but one of the other areas that we've recently just looked to implement was to bring in a volunteer, actually, with lived experience into our care and rehab centres. So we actually do have someone now who's in reaching as a volunteer to be a companion, be a friend, to some of our clients here with brain injury, and the volunteer himself has a brain injury. And as a part of own rehab journey, it was recommended because he is struggling with the return to employment, sense of value, roles within the family, and a part of him coming to our organisation has actually been recommended by his neuropsychologist in terms of assisting with himself, finding value and meaning in life. And it's wonderful for our clients to obviously have someone that they can have a chat to, can understand at a similar level, albeit everyone's individualised and has different issues. It takes away that sort of clinical therapy aspect. One might open up more, and we might actually be able to tap into a hidden area of disability or a hidden challenge that maybe as a direct clinician to clinician may be overseen. So for us, that's something else we're really trying to look at, how we can really identify some of these more critical problems that we see at an earlier stage, even if it's not that we can address them all in full, which I doubt we will be able to, but at least we can start that journey a little bit sooner.
Yeah, I think that's a great initiative, actually, of getting more people involved in lived experience, like Headway do, having support groups, but having sort of more of a ambassador type role for brain injury and around education. And actually, we're all sat having a round table now, but as professionals, but it's really important to get the perspectives of people and family and in education, and getting and in service design as well, and in, being involved in policy and decision making. And I think, that's becoming more and more important in healthcare and research as well, service user perspectives and involvement. So I think that that's quite important in education. I mean, we put a lot of emphasis on brain injury education here at QEF, and I think that what we increasingly see is that people are coming to us from the acute phase, and they've not had any education about, that they've got, medical terms for the symptoms they're experiencing, that this might be aphasia, or this might be, this is hemiplegia, or they've got cognitive issues. They've not been, and their families also, so we're seeing that they haven't had that education. And I think that again feeds into the fact that NHS services are really stretched, and really prioritising high needs sort of risk, and they're not getting into that more sort of education, not having the time for education. So we're having to spend then a lot of time on that. But it really is key for people understanding what's happened to them, for accepting what's happened to them, and learning to adjust and make changes. The education is absolutely key, pivotal.
Thanks, Kirsty. Mira?
Yes, 100%. I agree with Jenny and Kirsty. It is key in everything we do. When it comes to education, I think it's family education could be, we give them like leaflets, or we devise some particular documents in regards, let's say, to prolonged disorder of consciousness, because sometimes some of the patients' presentation could be misinterpreted. Because the family member just doesn't have this speech and language background or a nursing background or so. So yes, we do educate with a lot of leaflets and information, but also we educate practically. So we would invite family members to do with us like joint sessions. We discuss the results. We just educate them and make them aware what are the signs we would be looking for. So when they come and see the family members, they could be we're not asking them to imitate what we do, because they are the family member and they shouldn't be taking the role of a speech and language or a physio or so. But then they would be better aware and better educated on what signs to look for, how to interpret signs, so we can manage expectation in a very smooth way. We would tackle all of these things in MDTs. We do a lot of formal and informal multidisciplinary teams meeting, just to listen to the family's expectation, the patient himself, what do they expect from the family. We involve them if they are able to do so in their goal setting, let's say, things like that. We would involve them in activities of daily living, like cooking, and we could invite family members as well. So this is when we talk about educating family members and the patient themselves, but there's the staff as well, like HCAs. If they're not speech and language therapists, we might not expect them to 100% know everything about dysphagia. So we would run a lot of trainings for the staff members as well. It could be induction trainings, but it could be like fun trainings, like tasting different consistencies of food and getting more involved in knowing their patients and knowing the residents and what works best for them as well. So it goes both ways, and us educating ourselves about somebody else's, like another team member's role and so.
Thanks, Mira. We've covered a lot of ground, so I'm going to start to sort of draw the discussion to a conclusion. And I'd like to do that by asking all of our panel members to just provide a quick summary, if you like, a soundbite, a very short statement that's either aimed at decision makers and legislators, what could change and what would help you do even more to support people surviving with brain injury and their families and all those associated with them. Or alternatively, what's the one big thing you would like to see change that would help you and your organizations achieve even more for your clients and the people that you work with? So if you don't mind, I'll start with you, Jenny and Kirsty, and we'll work our way around the panel. Just a a short, sharp soundbite for those things that you would like to see change, or a message to decision makers and legislators?
I think for me, I think where is the patient and the family voice in all of this? I think to make a change and change this at system level and policy level, we need to be going back out to those survivors of head injury and their families, speaking to them, collecting the data, understanding where the problems are, and to work backwards and how we're going to change that. I think there's a lot of discussion, a lot of wider discussion from the acute side of things, how we can follow on with rehab. But actually, we need to bring the client and their families, patient voice, family's voice into the decision making, because they know best. We need to hear from them and understand from them where the challenges are. So then we work backwards as to how we stop the situation continuing to get to the stage it's at. Because I think without having them part of this journey, we're never going to get it right. And I really want to see that happen.
Great, thanks, Jenny. Kirsty, soundbite.
Yeah. My soundbite is acquired brain injury is a lifelong condition, and it has quite serious ramifications economically, societally, and the government and policymakers need to take note and hopefully do something about it from a systems and funding perspective.
Brilliant. Loud and clear. Gayathri.
I think I've got a highly skilled MDT, and we do the best to, get our patients to recover in an inpatient setting. And I think our aspiration would be to be able to do this in the community, so we can successfully discharge patients home and also provide them that long-term sort of aftercare that they need to sort of continue along with their journey. Thank you.
Thanks, Gayathri. Mira?
Yeah, it's again helping this patient from early on period, like the acute period, basically, just signposting them early on, getting to know where to go, getting to know what's out there from an acute phase, even before they are discharged home or to a care centre or so. But also one other thought that I wonder, now everybody's talking about AI and the technology, and so how we could just benefit from this, just to cover this gap until we can get these patients referred to a particular service. Technology now is booming, so there must be a way where we could benefit from AI and technology just to fill in these gaps, I think.
Thanks, Mira. I can feel another discussion coming on that subject at another date. Jenny from Cleveland.
I think that we and our teams are so passionate and have so many skills to offer people with brain injury, and we just need a central and systematic improved communication so that we can offer that and they can access it.
Brilliant. Thanks, Jenny. Penny.
I think for me, there's something about the whole system, and I think we've all got great models of inpatient and community, and probably some lifelong stuff. We always put in a contingency, and we have clients actually that once they've got their settlement that come back and use that at certain points, particularly when we have young clients that may have a baby or move house or change career at some point in the future with their brain injury, particularly they need support through that. So I think there's something about the whole system that needs some modelling, and then some basics pulling out that every area should have, that every location, because this postcode lottery is a nightmare for users and their families. And I also think that there's a great need for deinstitutionalizing, slightly demedicalizing as well.
Thanks, Penny. That's great. And Jen, you get the last word.
Again, as I was listening to everybody, I'm going, yeah. I agree with all of those things. So I think we are all incredibly fortunate that we get to provide brilliant care for adults living with brain injury in the facilities and the teams that we work in. And there are two things that I'd like to pick up with that. One, it's that should be available for everybody, regardless of your funding stream. And we shouldn't have to fight, and it shouldn't be down to individual connections to allow people to achieve the best that they can, and that people should have access to that level of rehab, that level of social support for the duration of their lives, because it's a long-term condition. And we do amazing work across this whole panel, and even we find it difficult to access those services. So I think it's really sobering to think what it's like for people who don't have access to the services that we can provide. And there is so much that has got to change, but at least people are talking about it.
Thanks, Jen. And that concludes this NR Times roundtable on surviving brain injury and rebuilding lives and families. I'd like to take this opportunity to thank all of our panelists and their organisations for being so generous with their time, with their experience, with their passion as well. I think anybody involved with the community of those surviving brain injury or caring for people that have brain injuries will be enormously encouraged listening to this discussion, not just with the volume of work and effort that's taking place at the moment, but with the vision relating to how further improvements could take place over the months and over the years ahead. For all those that are watching this, thank you for watching. Please share this as widely as possible. I think this discussion should be seen by the biggest possible audience. And I hope some of the legislators and decision makers will be watching and listening to some of the thoughts and ideas about how further progress can be made. So thank you for watching. Thanks to our fabulous panelists. And hopefully we'll pick up some of the themes in further NR Times roundtables. Have a look at the NR Times website, more details to follow. Thanks again.